Okay, good afternoon, everyone. We'll go ahead and get started. I know it's a little bit early, but I wanted to give our speaker as much time as possible for today. Just before we start, a couple of announcements. First, please pay attention to the slide on your screen right now. This is the UC Health Safety Culture Survey. I know we get a lot of surveys from our health system and our schools. This one's really important. This is the one that the system actually uses to think about how they're doing in terms of safety and priorities. It takes all of 5 minutes to do it. If you haven't done it, please do. There's a QR code up there. You should have also received an email if you are eligible for this, but I just want to make sure you guys are tracking on this. It closes next Monday, so we have a limited window to try to get it done. And now, let me pivot to introducing our speaker. It is my honor to introduce Dr. Robert Wachter, one of the most influential voices in modern medicine. Dr. Wachter is professor and chair of the Department of Medicine at the University of California, San Francisco, where he leads one of the nation's largest and most respected academic medical departments. He's widely known as the father of the hospitalist movement. He coined the term hospitalist in 1996. He helped launch what has become the fastest growing specialty in American healthcare. His visionary work has also shaped how hospitals deliver care today, and countless people, many of whom are in the room as well. Bob is also one of the world's leading experts in patient safety, in healthcare quality, and in digital transformation. He has authored more than 200 peer-reviewed publications, several landmark books, including the best-selling Digital Doctor, and the definitive textbook that I read when I was a fellow called Understanding Patient Safety. His leadership actually extends far beyond UCSF. He served as the president of the Society of Hospital Medicine, the chair of the American Board of Internal Medicine, and he's also been an advisor to major healthcare organizations and governments. Most notably, he chaired the UK's National Advisory Group on Healthcare Information Technology. He produced the influential Wachter report, which basically helped shape the entire digital strategy of the National Health Service in the United Kingdom. Bob is an elected member of the National Academy of Medicine. He's a master of the ACP. His career is one reflected by innovation, leadership, and profound impact, and I consider myself lucky to be one of his mentors and colleagues. Please join me in welcoming Dr. Robert Wachter.
Good afternoon. It is a great pleasure and honor to be here. This is an organization I have loved, respected, been pissed off at when you recruit my faculty, which you periodically do. And it's just a great pleasure to see the amazing things that are going on here. Vineet, thank you for a charitable introduction. My mother was wondering if her fax came through, so it's nice that it did. I've known Vineet since he was an academic child and have admired his career. You were very lucky to have him, and it's remarkable to see how this department is thriving under his leadership. So it's really been a joy to be here and get a chance to meet many of you and catch up with a number of old friends. I'm going to talk about, let's see if we can get this forward. I'm going to talk about artificial intelligence today. It is sort of what I'm thinking about most of the time these days. I think it is in some ways the most interesting issue happening in medicine, maybe the most interesting issue in life. And as I mentioned last night, I think we are in the early stages of probably the greatest experiment in the history of medicine, which is this could go in 100 different ways, some of which are incredibly exciting, some of which are concerning. And I'll try to give you a little bit of the lay of the land. I've spent the last 2 years thinking very hard about this, interviewing about 110 people in the process of writing a book. Vineet was kind enough to buy a bunch of copies, which are sitting outside. I'm happy to sign some if people like them defaced afterwards. But through that process, I've really been trying to do a deep dive into what this means, what its implications are for being a patient, for being a doctor, for being a nurse, for being a health system, and for society more generally. I think it's about the most interesting issue in the world. This graphic here was drawn by AI. This is Nano Banana, which is the graphical tool in Gemini, which is Google's AI tool. And I said to it, draw a diagram of a person who is optimistic, who landed in an optimistic place thinking about AI, and is optimistic for two reasons. One is generative AI's novel capabilities, the amazing things these tools can do, and also healthcare's desperate need for transformation. And that is what it drew in about 10 seconds. So just to give you, those of you that are not playing with AI a lot, just a taste of some of its remarkable capabilities. And that is a little bit of the theme that I want to focus on. This is Eric Topol, one of the great leaders in American medicine, a proud UCSF residency graduate, I like to say. And Eric, in blurbing my book, wrote, he called it an engaging, hype-free case for informed optimism. And that's kind of the theme that I want to play out for you, kind of why I landed in a place of informed optimism as I think about AI in healthcare. I am perfectly capable of being grumpy about digital transformation. I know that because I wrote a book 10 years ago, as Vineet mentioned, about the electronic health record, and mostly about why the transition from paper to digital went so badly and why there were so many unanticipated consequences. I'll mention a few of them later. But in this part of my thinking and at this stage of my life, when I spent 2 years thinking hard about AI, that's where I landed. Now, it's been very nice. The reception to the book, which came out about a month ago, has been incredibly lovely. It's selling well. The reviews have been great. And people have said to me, one of the things that was nice and surprising about it, the book, is it's very readable, lots of stories. And people have said, I can't put it down. So I want to show you a video of one person who could put it down. This is my granddaughter, who I gave the book to. The book is called A Giant Leap. So she likes leaping around the house with the book. And here,
hold up the book.
So give me the book.
We need the. Oh.
So she is capable of putting it down. Many others are hopefully are not. So here's my agenda. I'm going to talk about why I landed in this optimistic place. A little bit about the world of healthcare AI today, because this has gone from novelty and pilot trials to, in some ways, normalcy in a very short period of time. We are not rapid adopters of certainly general purpose technologies that transform everything that we do. How do we know that? It took us 20 or 30 years to adopt electronic medical records, and we only did it after the federal government gave us huge incentive payments to do it. So we're late adopters, but in this world, we're actually quite early adopters. If you look at industries that are adopting AI quickly, healthcare is at the top of the list. I'll tell you a little bit about why and what's happening that I see. I'm going to spend a minute, because I'm here, talking about the implications for medical education, which I think are interesting, profound, and difficult. A little bit on the task for leaders, and I'll end with A, are there going to be doctors in the future, and B, what the meaning of being a physician will be in an era where we all have these tools that in many ways are smarter than we are on our computer or in our pocket. So let me just first make clear, I've already told you that I've landed in an optimistic place. I'm confining that optimism to healthcare. I and everybody else is actually quite worried about AI and the rest of the world. That will bleed into people's opinions about it in healthcare. This is a survey that Gallup did last year, asking the question, how do you feel about AI? Do you think it's going to be net negative, net positive, or something in between? And net negative is orange, and the positives are the green here. And you see overwhelming majorities of people who are worried about it in terms of spread of false information, social connections, jobs, national security, detecting criminal offenses. The only area where people were positive was in medical diagnosis and treatment. So I think the general public is probably mirroring the way I feel, which is I'm optimistic in healthcare, in some ways mixed, or maybe even net a little bit worried about it in the rest of our lives. But we'll be talking today specifically about healthcare. Now, I've already showed you this slide. So this was Nano Banana talking about the reasons I'm optimistic, and to me, both reasons are equally important. Both reasons really reflect the fact that not only are these tools remarkably good at what they do and getting better fast, but healthcare needs it. In fact, I think healthcare's desperate need for transformation is part of what makes me particularly optimistic. Let's talk first about, though, generative AI's new capabilities that we were not aware of and didn't have access to until generative AI rolled out. So this is my own learning curve over the last 3 years, and it reflects the learning curve of AI. These are published studies looking at things that the new AI could do. And if you're like me, as you read each one of these studies, it was a little bit head spinning. It was like, oh my God, I can't believe it can do that. So it began in November 30th, 2022 with the launch of ChatGPT. And then a year later, you started having studies showing that it could beat trainees on licensing exam and other tests like that. And that was like, okay, fine, it can take a test. That's sort of like, you know, watching Watson beat the Jeopardy champions or AI playing a game of chess, fine. But that doesn't reflect its ability to puzzle through a really complex case. And then later that year, studies showing that actually it can puzzle through a really complex case. They began giving it cases, the case records of the Mass General Hospital, wildly complex cases, and it did as well as the faculty experts. If you hadn't had a chance to read the case records of the MGH from about 2 or 3 months ago, where our top diagnostician, Gurpreet Dhaliwal, one of the great diagnosticians in America, was pitted against AI, and he did better than AI, but only marginally so, and the AI sorted itself out in a couple of seconds. It's really quite instructive. So it does really well on really complex cases. This was then the next two are kind of my, oh my God, kind of moments, because I think at this moment, after reading the New England Journal cases, it was like, all right, it's pretty smart, it's probably smarter than I am, but you know, complex cases, that's really tricky. All right, it's pretty good. And then it's like, all right, I don't have complex cases anymore, but at least we have communication and empathy, and we will need doctors for talking to patients and listening to them and delivering bad news. And then studies began to come out showing that in blinded trials, patient actors who were given access to communication either from AI or from a doctor, and they didn't know which was which, tended to rate the communication from the AI more highly than they rated the communication from the doctors. Now, some of that was the AI had more time to do its thing, and the responses tended to be longer, but in fact, the AI has more time to do its thing. And so, all right, maybe we don't, if our main defense is we're really good at empathy and communication, I'm not sure how long that will hold out. And then a study you probably remember about a year and a half ago from Harvard and Stanford, looking at a measure of diagnostic reasoning. And the humans did reasonably well, and the humans with AI did a little bit better, but the AI by itself did by far better than the other two alternatives. In other words, the human in the loop, and I'll talk more about this in a few minutes, but the human in the loop, the human looking over the shoulder of the AI and saying, all right, the AI gave its answer, I'm going to make the final determination. The human kind of screwed things up. The AI by itself did better than the AI plus the human. One AI expert at Stanford, John Chen, who I interviewed, said that this was my holy cow moment in informatics. Basically, the fundamental theorem in informatics has always been humans are good, technology is good, the two together are better than either one alone. And this was a study that basically tested that hypothesis and raised the possibility that maybe the two together will not be better than either one alone if the AI is really good. Now, I will also show you my learning curve this is over just 2 or 3 years, it gets this much better. And this is my learning curve, which is flat, and this is actually charitable at my age. It's probably descending slightly. So the humans are getting no better, and the AI is getting better every day. So this is, I think it's important as we reflect on its flaws and the challenges and all this, to say this thing is pretty darn good, does things that no AI before, no technology before could have done anything like this, and is getting better very quickly. Now, as soon as the new AI came out, though, there was clear evidence of things that it did that were wrong, and sometimes almost in a caricaturizable way, like so wrong almost to be funny. Here was when you ask, and this were both, I think, with Gemini, with Google's tool, you asked it to show pictures of the founding fathers, and some of them were depicted as black. Turns out not to be true, sadly. And when you asked it, you said, I'm having trouble today. The cheese is sliding off my pizza. It said, I know how you can fix that. You can put glue on your pizza. Now, to be fair to the bot, it said non-toxic glue, but nevertheless, this is not a perfect answer. So these sort of hallucinations or kind of wacky answers, or people had examples of sycophancy where it's just telling you exactly, you would give it some crazy answer, and it would say, oh, that is so smart. You know, you came up with that really innovative answer. No, it's wrong. Those sort of things in some ways gave the early AI a little bit of a bad name, and many led people to say, all right, maybe I can use it for a recipe or get directions or plan a trip, but using it in a high stakes enterprise like healthcare where we can kill somebody if we get it wrong, it's not going to be ready for prime time. It's important to say that it has gotten a lot better over the last 3 years, and if you played with it in 23, you should go back and play with it again today because it's a different set of tools, and it gets better really every several months. And here's my scorecard of kind of the main flaws that have been brought up. I have a chapter on each of these in the book, so obviously this is quite quick. But here is at least my own personal judgment of where these stand. Accuracy and trustworthiness are not perfect, but they're markedly improved, and the frequency of things like hallucinations is much, much, much lower than it was 2 or 3 years ago, and you're probably seeing that in using an AI scribe or when you go into tools like Open Evidence and ask for help with a diagnosis. It's not perfect, but it's pretty good, and it's gotten a lot better just in the last year. Biases are interesting. Obviously, the current political climate is having an influence here. But my own sense is that it was overemphasized in the early days because it was an era where we're thinking a ton about bias, in some ways appropriately. But humans are biased too. In some ways, the AI bias was mirroring human biases. And there were some early discussions about AI saying we could never use it because it's biased. And to me, that was overblown in a way because bias is really important, but more important that it gets the answer right. And so I think in some ways bias has taken on a more appropriate, it is one of the things we should pay attention to. It is better than it was. It's not perfect, but it's not the only thing we should look at as we decide whether an AI tool is trustworthy. Black box issue is an interesting issue. We talked a little bit about at a group last night. It's, in the beginning, people thought people will never use tools like this in medicine because the tools can't explain how they came up with the diagnosis of lupus. I think it turns out that humans don't care that much about explainability, and I know this as a physician. I actually have no idea how Tylenol work or anesthesia works. I just use them because I know they work, and they've been approved by a generally trusted regulator. And also the tools are getting better. So in the early days, they could not explain to you how they came to an answer. If you say to it now, how did you come up with the diagnosis of lupus, it will tell you how it did. So they can do what's called reasoning now in a way that they couldn't do 2 years ago. I think privacy and security is a growing concern. In some ways, it shouldn't be a greater concern than we already had. You're already taking your data, putting it in a database of a company, in your case, my case, Epic. And there are issues if it can get hacked. But Epic has never been hacked. The privacy rules, they operate under HIPAA, which if you take all your data and you put it into GPT or put it into Gemini or Claude, they do not operate under HIPAA. So there's some concerns as more data goes out there, it's flying around to more places, and we're dealing with entities that don't have the same regulations on privacy and security that electronic health records have. There are some concerns. To me, the biggest concern of all is mis and disinformation and essentially deepfakes. Now, this is a double-edged sword. I start the book out with a scene where I was sitting in the office of the CEO of the Mayo Clinic, and he showed me a video of a doctor, very empathic doctor, talking to a patient about her x-ray results, patient with rheumatoid arthritis, and he was going through what the results show, what they mean, and then in behind her, awkwardly walked his twin. And he waved to the camera, and then he walked off stage, and it became clear that the person talking to the patient was actually a fake, was an AI digital twin of a real doctor. And he said to me something I'll never forget, which is that when the Mayo Clinic 30 years ago decided it was going to expand beyond Rochester, Minnesota, what did it do? It built campuses in Scottsdale and in Jacksonville. He said, today we wouldn't do that. Today, we would think, how do we leverage AI to scale our expertise and our influence to more people and more places? It's an incredibly interesting shift in mindset. And yet, on the dark side of exactly the same technology is a deep fake that could have me saying to you, I don't believe in vaccines. By the way, I do. And it would be perfectly credible and look like me. Now, I hear that the audio on the Zoom may not be working. Is that right? Not right? Not sure. So if you don't hear the audio, it's only a 5-second clip. Sorry, we'll be on in a second. Here's a deep fake that I created. Again, I think on Gemini. This took 10 seconds for it to produce. I gave it a picture of me rounding in the ICU, and I said, say something about deep fakes.
Don't listen to him.
Well,
Deep fakes are nothing to worry about.
All right, that is pretty creepy. That was easy for me to do. It doesn't sound like my voice, but it looks like me saying deep fakes are nothing to worry about. So that's the dark side of the digital twin, and there's a lot about AI that's like that. There's a wonderful part of it, and on exactly the next sentences, and it can do these bad things. Now, I've already told you about AI's improvement over the course of really only 2 or 3 years. Sort of November 30th, 2022 was when GPT was rolled out to the public. So only 3 years ago, that's how far we are into it and how much better it's gotten. This is Ethan Mollick, who is a professor at Wharton at Penn, who, if you are interested in AI and following AI, I think is the smartest person to follow. He's a professor of entrepreneurship. He writes about AI on a Substack. not in medicine at all, but in different kinds of work, in different types of educational settings. This is his book, Co-Intelligence, actually published by my publisher. It's a great book. But one of his rules of thumb is assume the AI you're using today is the worst you'll ever see. So anything that we think about what AI might do and can do, and it's based on your feeling today, this is unlike anything we've ever seen in healthcare. It's like, that's fine today, but a year from now, you're pretty sure that it's not going to be exactly the way things are. Things are probably going to be substantially better. So I think that's a useful rule of thumb. All right, I have told you about the sort of amazing capabilities of the AI, some of the challenges that we see and are working through and have to mitigate. But let's turn to the other part of this graphic, which is the other reason I'm optimistic, which is healthcare is in desperate need of transformation. And my own belief is AI is actually our only hope to do the things that patients need us to do. And part of the reason I say this is other industries did not need AI to rescue them. So I can tell you on November 29th, 2022, when I was doing a Google search, I wasn't sitting there saying, Google stinks. We need a better search engine. In fact, I'm not that creative. I couldn't even imagine what a better search engine would look like. To me, it seemed like Google was perfect. And yet, as soon as I used GPT for the first time, it was like, oh, this is better. I can put more information in. I can talk to it like a human. I'm getting out of it a text answer to my question, not a series of links I've got to click on. That's better. Obviously, the tools were flawed, and they've gotten substantially better. But nobody really needed a better search engine. It just happened to be this was one. And I know you have Waymo here. We have it in San Francisco. I'm a fan. It's not like I was driving myself or taking an Uber saying I needed a car driven by AI. And yet when Waymo came out, I think it's better. And if I'm in San Francisco and I see there's a 2-minute wait for an Uber and an 8-minute wait for a Waymo, and I will wait for the Waymo. I don't really want to talk to somebody. I can sing Springsteen in the back seat or sometimes take a nap. I just prefer it. So other industries, I think, have been improved by AI, but it wasn't like they needed AI in order to do their thing. And yet, I don't know anybody in healthcare who on November 29th, 2022 was saying, you know, healthcare is perfect. I can't imagine the system could be better. I don't know a doctor who said that, a nurse who said that, and I certainly don't know a patient who said that. Even patients who are coming to fantastic places like yours, when they get in the door, they love their doctor, they think they're getting great care, they are still complaining about access, getting information in their portal that's totally confusing, they have no idea what to do with it. There are lots of complaints about friction in the system, inaccessibility, inconvenience. I don't know anybody, maybe a few people who have, pay a lot of money for concierge care, who get the care they need at a cost of $20,000 or $30,000 a year above what the rest of us pay. But other than that, nobody thinks the healthcare system was perfect. Everybody believes, as I do, that the healthcare system is in desperate need of change. Now, our go-to strategy for the last generation, when we said, here's a need that patients have, and we can't fill that need with the doctors or the nurses or the system that we currently have, our go-to move was we hired more humans. So if you look at one of the great things about healthcare was we have been the full employment engine of the United States. And we continue, if you look at the employment report that just came out a few weeks ago, everything else is going down. Healthcare continues to go up. So you can always count on us to hire more people, mostly non-clinicians, mostly administrative staff to handle the billing stuff and the call center and the prior auths and all of that stuff. And patient with cancer comes in and trying to navigate this system, and I'm the oncologist and the infusion center and the rad-onc people, what do we need? We need to hire a care coordinator to basically hold the hands of the patients to go through this unbelievably complex system. That's just been our go-to move. The problem, of course, is we can't afford these people anymore, as our reimbursements aren't going up very much, but the costs of all of them continue to skyrocket. And in many cases, I'm not sure how it is here in San Francisco, often we can't even find them. There are not enough humans to do these jobs. And as I said, I think we have a system that no one's happy with. I will summarize a couple of chapters where I talked about sort of the predicament that we're in, but here are just two examples of where healthcare, I think, needed AI to do the things it needs to do for patients. Some of you have seen this before. This was a 7-year-old girl, went to see her doctor now a decade ago, and this wonderful artist, she drew this drawing of her recollection of the visit to the pediatrician. And you see there she is, there's mom, there's sister in the corner, and there, back to the patient, typing away is the doctor. That was her recollection of my visit to the doctor. Pretty realistic. I think this is a magnificent picture. There's one thing she got wrong. Anybody catch it? The smile on the doctor's face. There is not a single doctor who I know who says, I am now a data entry clerk and I'm really enjoying every moment of it. Nobody says that. And this did not happen when we were on paper. This is a side effect of electronic health records, where the electronic health records all of a sudden enabled everybody who cared about what the doctor did to say, if you could just answer this extra question, or 2, or 5, or 10, or check these boxes, we can produce a better bill, we can do better on our quality scores, we can get less likely to be sued. And all of a sudden the doctor had turned into this very expensive and very grumpy data entry clerk, and now you have and we have access to an AI scribe that does a pretty decent job solving that problem and is wildly popular among physicians. And at least in our place, if we turned off the AI scribe, people would leave and we would not be able to hire a new physician. So remarkable for a technology that was only invented 2 or 3 years ago. Here's another example of where we needed AI. So before I see a new patient in the hospital or you see one in clinic, you should review the patient's old record, right? Logical. This was a study that came out a couple of years ago. I love the title, Call Me Dr. Ishmael. It showed that 1 out of 5 patients' old medical record is longer than Moby Dick. For those of you who don't remember Moby Dick, that's 600 pages. The idea that you're going to be able to review a 600-page document in the 3 minutes that you have to do that is a joke. And so the only way we can solve the problem of summarizing these vast medical records is AI helping us do it. So these are just 2 examples of things that we've asked humans to do, but actually it is impossible that humans could do it without the help of AI. So this is partly what gets me enthusiastic about AI. These problems I don't think can be solved just throwing more humans at them. The other point I like to make is something Biden used to say all the time, which is when we compare AI, we shouldn't be comparing it to some mythical perfect system because we don't have it. Biden liked to say, don't compare me to the almighty, compare me to the alternative. So when we say, oh, AI in reviewing a 700-page chart is not perfect, neither am I. And it's still, and at this point, probably already likely to do a better job than I will do in 2 minutes. And as it gets better and better, again, as I will not, it's likely to do an even better job. So this is going to be an important point. Part of the reason it's important to build up a reservoir of trust with early AI tools, and I think we're beginning to do that, because at some point they will screw up and they will become an iconic case. You see, I told you we couldn't trust AI, but we should be comparing it to the current system, not to a system that we wish we had, but we do not. All right, I'm going to shift now. That's sort of all I want to say about AI, where it fits into the healthcare system. Let me talk a little bit about kind of where we are. This is at UCSF, and I think you're at about the same place. And I've titled this From Novelty to Normalcy. And again, I asked Nano Banana for its help, draw me a diagram of sort of a world where we were trying tools and doing lots of pilots to one in which we were actually implementing it in real time, and it was real. And this is what it drew. It's pretty impressive. Again, this took 10 or 15 seconds. So this is UCSF Medical Center. And here's the situation today at UCSF, and I think not all that different than here. All of our clinicians now have access to an AI scribe. We're using the same company you are. Massively popular, modest time savings, not as much as people had hoped for. It turns out the amount of time you save is about, in terms of if you translated some of that into increased productivity and seeing maybe an extra patient a day, it sort of pays for itself, but just that. But the business case is not that. The business case is much happier doctors, much happier patients, because they actually notice their doctors are making eye contact. And if you factor in the cost of recruiting, retaining, and replacing a physician, it pays for itself easily that way. We also now have access to an AI chart summarization tool. Again, charts 500 pages long, useful, and an AI tool that will draft a discharge summary. Again, not perfect, but as people are using it, very helpful, and the initial feedback is positive. We're still testing them. We just launched patient-facing AI on the patient portal. Clearly, that is where things have to go. Since about 7 or 8 years ago, federal law said patients have a right to see my note, their lab tests, their EKG results, their X-ray results, and we gave them precisely no help in interpreting any of it. So we have to build tools that allow them to see what it means, and not just what it means that I have a low magnesium or an abnormal EKG, but what it means for you, which means it has to understand your past record and the medications you're on. So it has to get embedded in the electronic health record in order for that to work. Tools are coming out to do that. Back office, we and you are using a lot of this for billing and coding and for the call center, things like that. Population health, communicating with patients that it's time for their colonoscopy, et cetera, things that AI can do quite well. And clinical decision support is interesting. We have early versions of it. I think you're ahead of us in clinical decision support, in part because of you're really ahead of the curve thinking about virtual care. We're getting there. The tools so far have not been that great, but to me, may turn out to be the most important issue, the degree to which AI enables us to give the right information to the right person at the right time in ways that fit into the workflow. Right now, a lot of clinical decision support is in some ways happening organically and offline. And by that I mean, I frequently on rounds pull out my phone and put in a query into Open Evidence, which is, for those of you who don't use it, essentially GPT for doctors, and use it essentially the way I would have in the old days used a curbside consult, hoping I would run into my favorite ID doctor, but now I'm using an AI tool to give me information that is essentially scaling subspecialty knowledge. And in general, I find it very helpful, generally accurate. It provides links to the primary data, so super helpful. To me, that is where all this goes. And I sort of think about it that reducing paperwork, whether it's with chart summarization or scribes, is nice. But in the baseball metaphor, these are singles, they're not home runs. The home run really is robust and accurate, trustworthy clinical decision support that helps us make better decisions and choose better therapies. An old saying is the most expensive piece of technology in a healthcare system is the doctor's pen. It's no longer the pen, it's your fingertips. But what the saying means is the doctor's salaries are actually a pretty small part of healthcare expenditures. Doctors' decisions make up the majority of healthcare expenditures. And doctors' decisions often are not evidence-based. It takes 17 years from a new finding to integrate its way into clinical practice. You can imagine easily how AI would get embedded in the system of care, in probably the electronic health record, help guide you by suggesting diagnoses or monitoring a patient and saying, you know, you said this patient had pneumonia, but it's now day 4 and the patient still has a fever and a white count. And I've just reviewed both the literature and guidelines and the last 10,000 patients we saw here with pneumonia, and 98% of them don't have a fever and a white count by now. It might be time to rethink the diagnosis. That sort of thing is just going to happen, and relatively soon. And so this is just Open Evidence and examples of things it can do. I have no financial connection to them at all. I just am a fan. I'm not the only one. It's recently valued, this company that's only a couple of years old, recently valued at $12 billion. And it's pretty cool. How many of you use Open Evidence? Raise your hand if you use it. Almost everybody, and this is a tool that did not exist. When I started writing my book, I'd never heard of it. And my son-in-law, who was a senior resident at UCSF, said, Bob, do you know, like we're all using Open Evidence? We just tried it like 3 days ago. And so the residents are always the early warning system about where the world is going. They will pick out the best tools, and that's what's happened here. All right, let me shift a little bit. So that's where things are. I just want you to reflect on that. May seem a little ho-hum, but the fact that those tools over 3 years have been adopted and are being used by almost everybody in these complex bureaucratic healthcare systems that don't adopt new things very easily is absolutely remarkable, sort of breathtaking, and demonstrates the kind of curve that I think that we're going to find ourselves on. When I started writing the book, I actually was a little reluctant to write it for a little while because I said anything I write is going to be out of date 5 minutes after it's out. And my publisher, to her credit, said, if that's the book you write, then you've written the wrong book. You know, and what she did and inspired me to do was try hard to think about what are the big issues that arise when we have a technology that's really good but not perfect, that's getting better every day in a complex environment where if we get it wrong, we can kill somebody, that makes up 20% of our GDP, and has a long history and a lot of incumbents who have very strong feelings about their work. Really complicated. So how to think about this. This was one of the issues that came to mind and I think is quite important as we think about this all kind of philosophically. It's the human in the loop issue. And here's how I frame it. I'll sort of frame it between two poles. If the AI was right half the time, let's say as a scribe or suggesting diagnosis, it would be worthless because you'd be spending so much time reviewing its results and correcting it, you would just get rid of it. You wouldn't trust it at all. If the AI was right 100% of the time, that's pretty magical. We will employ it enthusiastically. What we're all going to do for a living is anybody's guess. We'll get back to that in a few minutes. But we will not need, and not only will not need, but we shouldn't have a human in the loop because the AI is perfect and the human can only do one thing, which is degrade its performance. Those are the two poles. We are going to find ourselves between those two poles for the foreseeable future, which is a pretty weird, uncomfortable space. And between those poles is the AI is right often enough to be useful and wrong often enough to not be entirely trusted. And then the question is, what do you do? Well, what you do is you say, well, the system is co-pilot, augmented intelligence, human in the loop. The human will be the final decision maker. The human then will be left holding the bag if something goes wrong from a litigation standpoint. There are a number of problems. That is a system that sounds better than it is. And one important problem is vigilance, which is this is not a thing that humans are good at. The idea that I am going to really read that note carefully when the last 20 times the AI gave the right answer. Am I really reading it carefully on time 21? Probably not. It's just not something humans are good at. Then there's the issue of de-skilling. We'll come back to that in a minute. How could you even begin to think about human-in-the-loop systems that work? I think it's something we should be thinking hard about, studying, empirically testing different models. One, maybe the AI can suggest its level of confidence. That's a tool, that's something that the companies are working on. It could say, this thing I'm 100% sure I'm right on, and here's why. This thing I'm not entirely sure, maybe it's green or it's yellow, and the yellow one signals to human, this is something you should look at really carefully. That's not technologically infeasible. Also, maybe if you think about your fish testing, you guys probably do that, sending out an email that's a fake periodically to see if you're awake. I don't know if you know this, but TSA at the airport periodically throws in an image of a bomb or a gun into the video feed, so to make sure the TSA folks are awake. You could imagine we do something like that. We throw in a wrong diagnosis periodically or a mistake in your AI transcription. We'd have to have a pretty fail-safe system to make sure it doesn't make it to the patient. But to test to be sure that you're awake, you could see systems like that, but we'll only develop them if we are thoughtful and not too magical about thinking about, oh, our system's safe because there's a human in the loop. It's not a fundamentally safe way of organizing ourselves. I think there's a lot of work to do. Okay, let's spend a minute on medical education. I think really interesting, challenging issue, one we're all grappling with, those of us in places like this that have medical education is a huge part of our mission. One part of this I think is super clear. We have to teach people about AI. I know you guys are doing it, how to build it, how to use it effectively, responsibly, what's a hallucination. Maybe a little bit less than we would have thought a few years ago, and how to put in a perfect prompt. The tools have gotten so good that's less important than it once was. But in some ways, how to be the human in the loop and use it effectively, I think that's an important addition to the curriculum. The harder question is, are there things that we can take off the curriculum because we essentially have offloaded them, we've outsourced them to the AI? And I worry a lot about that. I think there is a tendency to say the AI is so smart, it can come up with a diagnosis. We therefore don't need to teach students about differential diagnoses, how to come up with an illness script, clinical reasoning. I think that would be a huge mistake now because the tools remain immature and we're going to count on the human to do their part of the job correctly. I chaired a national conference on this for the Macy Foundation last year, and we received complete consensus on one thing to remove from the curriculum. Anybody want to guess? I heard the Krebs cycle. Now, it's poor Hans Krebs. So that's the only thing everybody seems to agree with. Now, I said that last night to the Clinical Excellence Society, and there was one person who said, no, you can't remove the Krebs cycle. So even this one thing that we sort of agree on is like, no, that's foundational to all these other things. So this is going to be really hard, but I think in the short term, if we made an error taking off too much or taking off too little, I'd rather make the error of taking off too little and continuing to train people in how to be smart clinicians. I think they need that for a while. Now, it gets us rapidly to the issue of de-skilling. In that case, in that context, we're really talking about never skilling, like that they never learn how to the differential diagnosis of leukemia or rheumatoid arthritis. But there's also this issue of de-skilling. And we've seen examples of it from other industries. These are two awful plane crashes. And both of them had a similar thing go on, which basically the technology tools that the pilots had learned to count on stopped working. In the Air France flight, it was a little gizmo on the outside of a plane that gave them the airspeed and the angle and all that sort of stuff, and it froze in a storm. And they were in a storm at night, they couldn't see where they're going. And the pilots in both cases did precisely the wrong thing and crashed the planes. And I remember interviewing Captain Sullenberger, the pilot who famously landed his plane in the Hudson. And Sully had learned to fly in the Air Force and learned to fly gliders. And he said these pilots, sadly, were flying a plane they were unfamiliar with, which is a plane that did not have their technology, its technology wingman. And now that said, I'm going to fly tonight. It's safer to fly today than it was 15 years ago because of the technology. So this is not an argument to get rid of the technology. It is an argument that we need to think carefully about de-skilling. And there may be times where de-skilling is fine. As I've said to people, I don't know how to read a map anymore. It's fine. I don't have to. It's a skill I once needed but don't need anymore. There are going to be lots of them like that in medicine. We shouldn't think about de-skilling in some overly romanticized way. You know, people really need to know how to palpate the spleen from this angle, blah, blah. You know, maybe not anymore as they can use POCUS or they have other new technology tools. But there are times where de-skilling is going to be quite harmful. And I think it's one of the great challenges of medical education to figure out how to get it right. Now, the first real study of de-skilling in healthcare, which I know has been a little controversial, but I think had a fairly convincing result. This was from the world of colonoscopy. It was published in Lancet a year or two ago. This was a study where they took very experienced gastroenterologists, average one had been doing colonoscopies for 10 years. They gave them exposure for 3 months to a now state-of-the-art AI-enabled colonoscopy tool that helpfully puts a little green box around suspicious lesions. The gastroenterologists liked using the tool. It improved their performance, and then they turned it off. And then they followed them over the subsequent months. And it turned out that their performance, which is sort of the percentage of patients where they find suspicious lesions, degraded significantly from before using. This was in 3 months exposure to this AI-enabled tool. So whether that is going to turn out to be true, generalizable, I don't know, but it raises the question of, even in experienced people, a relatively brief exposure to an AI, you might say, crutch, it made them worse performers when they didn't have access to that. And I go through this all the time as I'm writing and asking, you know, if I'm using Claude to help me write something, is it making me a better writer or a worse writer? I've been writing a long time and I'm decent at it. I'm okay with it. But for a kid to be able to put a prompt in and get an essay written, pretty sure that's going to make them a worse writer. Now, again, it may be like the spleen. It's like, it's okay they're a worse writer. The tool's really good. You know, it's not important that they learn spell checking anymore. The tools are really good. But I think it's something in medical education. To me, it's probably the most important issue for the next generation of medical educators. Now, which human in the loop matters a lot, and I think this is important as we think about medical education. We've seen a couple of studies in the last few months come out that looked at patients' use of AI tools for their own diagnosis. And they all come out with pretty concerning results. And what they basically say is that even though GPT or whatever are pretty good tools, that when patients are putting information in, they're actually getting wrong answers and they don't know that they're wrong answers. And what it says is patients are novices when it comes to healthcare. And they don't know two very important things that experts know. I didn't really fully understand this until I was writing the book, and Peter Lee, who runs research for Microsoft, said to me, as you think about these tools, you have to think about novice use and expert use in very different ways. And the same tool that will work perfectly for an expert will be really bad for a novice. And as he explained it, it feels right. When you take a patient's history, you may have 200 facts at hand, their past history and their past surgeries and their hospitalizations and the 14 meds they're on, and now they come in and they've got chest pain or a headache or whatever, and they give you 4 other symptoms. And then you distill that into, this is an 82-year-old man with CLL who comes in with a fever and a white count and an infiltrate on chest x-ray and a creatinine of 2.7. That is a remarkable cognitive act. A massive amount of education and experience went into you taking 200 facts and distilling it down into those 7 things that go into the prompt. Patients have no ability to do that. They have no idea which of the 200 things are important. On the back end, when the tool comes out and says, here are 5 potential diagnoses, I can look at it and say, you know, number 1, yeah, smart, I thought of that. Number 2, oh, I hadn't even thought of that. That's really helpful. And number 4, that's stupid. That's ridiculous. I'm going to throw that out. A novice has no ability to do that. So as patients use these tools, even the same tool that you might use and say, this is great, a patient can use, and it could be quite dangerous. on both ends of it. Does that mean patients shouldn't use them? I think it's probably better than nothing. I encourage patients to use two different tools in order to, if they both agree, it's a little more likely, it seems right. But I think the future of tools for patients will be much more doctor-like, much more iterative. Patient says, I have a headache. It knows the patient's past history. The tool then says, tell me about it, character, how long it's lasted. Does a bright light hurt your eyes? Does your neck hurt when you bend it? Back and forth, just what a clinician would do. The current tools don't do that very well. The reason I bring that up when I'm talking about medical education is I watched my daughter go from first day of medical school when she was a novice, she was a layperson, to graduating when she was sort of almost a doctor. And basically that is a journey of novice to expert. And by the end, she uses the tools like an expert. In the beginning, she uses the tools like a patient would. Those are very different use cases. So as we think, and this is the study showing that large language models as medical assistants didn't work very well. So as I said, the expert knows how to create the case scripts and vet the data and can interpret the outputs. And med students are sort of on this halting journey from novice to expert. We have to think about them that way and recognize in the beginning they're really lay people, and we have to, in some ways, treat them cognitively that way. All right, a couple of minutes on implications of all this for leaders of health systems and people in leadership roles. Here are the things I think of, that the work of leadership is to create a nimble and effective governance structure, including to select the use cases and, importantly, gain buy-in. And I think one of the things we've done right this time is start with things like scribes and chart summarization that are relatively low risk, relatively high reward, quite popular to win over the hearts and minds of the clinicians and open them up to broader, more far-reaching, probably riskier kinds of technologies. Analyze return on investment, vet the tools, figure out how to train the staff and everybody on new skills that they need and how to prevent de-skilling, privacy and security concerns. Figure out a system for monitoring whether the tools are working, not just on day one, but on day 365. It's a really hard task, and I'm pretty sure a lot of the monitoring will be done by AI, looking at AI, which is weird, but almost the only way to get this done. And strike a balance between enthusiasm and skepticism, which is tricky to do, but here was the CEO of the Mayo Clinic, Gianrico Ferrugia. When I asked him, you've got the best brand in healthcare, you must be concerned about going too fast and screwing up and ruining things. And he said, I think the risk of not going fast enough is far greater than the risk of going too fast. I actually think that's right. I think this is going to move very quickly, and we can easily find ourselves behind the curve. Other thing that leaders need to do, which is really tricky, is manage their staff's anxiety about jobs. Because when you're talking to them about AI, they're listening and they're also worrying, is this thing going to take my job? So that's a tricky thing to do. Talk more about that when it comes to physicians. But here is the largest national nurses union 2 years ago coming out against, quote, untrustworthy AI, and obviously worried about job replacement. My own belief is this will not replace the jobs of many clinicians for a while, in part because the unmet needs are so vast that the clinicians mostly will welcome it in. And I'll give you my best example of this. This is Jeff Hinton, a very brilliant guy, won the Nobel Prize 2 years ago, and is basically the founding father of the new AI. Was the person who sort of came up with the idea of using neural networks and all that. And he's a brilliant guy and is almost always right, but not always. In 2016, at a conference in Toronto, where he lives, he said, I think we should stop training radiologists now. It's obvious that within 5 years, deep learning is going to do better than radiologists. So that was 2016. So that should have meant that by 2021, the radiologists were toast. Now, it's easy to mock this. I probably would have said the same thing 10 or 15 years ago. And if you asked me which comes first 15 years ago, our radiologists don't have jobs because they've been replaced by newfangled AI, or I get into the back seat of a driverless car and take a nap as it's making a left turn across the Visadero Street in San Francisco during rush hour, I would have said the radiologists are toast. And yet in San Francisco, as I say, I take Waymos all the time, and we can't hire radiologists fast enough. And our radiologists are begging for more AI because the hamster wheel is going so fast they can't get their work done. So it's interesting, and I think demonstrates that replacing physicians is harder than it looks, and that's in some ways the message. I think we're likely to insist on the doctor in the loop for a while. In part, the regulators may insist on it, the billing system will insist on it, the malpractice system will insist on it. Even in easy fields like radiology and pathology, it's harder than people think for a lot of reasons. I interviewed a lot of radiologists for the book, and my first question was like wildly obnoxious. Why do you still have a job? And they explained to me, and the reasons are multifaceted, partly because the AI was not good enough to do. It's good enough to detect lung nodule cancer, not breast nodule cancer, not good enough to do what a radiologist does, which is look across a myriad possible diagnoses with lots of human variation in anatomy, understand the past history, because sometimes it's relevant to the way to interpret the films. There's a lot of stuff that they do that is harder to replace than people think. As I said, I think our enormous unmet needs will mean that AI will not displace many doctors or nurses for the next 5 or 10 years at least, and I think that's a good thing politically, because if it was, we, of course, we're very good at saying, not, I'm worried about you taking my job. We would say it's going to kill people. Over a 10 or 20-year time horizon, anybody who tells you they know what's happening with AI beyond 10 years is making it up. I have no idea. I suspect that, I think I did this during med school when my daughter, I said to her, if you say I'm going to be a diagnostic radiologist, I think I said I'm going to withhold your tuition. That's a little bit on the obnoxious side, but I do think making a bet on a field like diagnostic radiology or pathology over a 20-year time horizon, I think is a little hazardous. I think there will be radiologists. They will do a whole bunch of other things that may involve tools that we haven't yet invented. But reading a chest film, reading a belly CT, probably not over a longer time horizon. But as Hinton saw, harder than it looks. I'm going to end with a brief reading from the book. And spoiler alert, this is the actual ending of the book. But it was something I thought very hard about how to end the book and how to tie things together. And it relates to on being a doctor in the AI era. I was ward attending at UCSF health system, it must have been 18 months ago. And as I was thinking about how to end the book, for about 10 days on the wards, I just tried to use AI everywhere I could, in every possible use case. And then also, to the degree a human can, fantasize about what might happen as the AI got better over the next, let's say, 3 to 5 years. Really trying to test the question of like, what part of my job could be done by AI, assuming it continues to get better. This is take about 2 minutes and then plenty of time for questions. Toward the end of my time in the wards, I cared for a 22-year-old woman with severe autism who was nonverbal at baseline. She was brought to the ER by her mother for fever, cough, and lethargy. In her case, the diagnosis of pneumonia was straightforward, as was the choice of treatment, IV fluids and standard antibiotics. I had no doubt that AI could have easily replaced my clinical decision-making. Still, and perhaps I'm being selfish, I treasure having been part of this young woman's care. As she emerged from her near comatose state, her mother's face brightened as she proudly told us that her daughter was back to her sassy self. Thinking of my own experience as a parent, I tried to put myself in this mom's place. I was awed by her resilience, her ability to find delight in loving a child who would never speak a word, for whom life's conventional milestones would always be out of reach. Lost in these thoughts, I turned toward my patient, only a bit younger than my team of residents and students standing by her bedside. Just then, the patient flashed us a radiant smile and blew kisses to me and my team. As I hope I've made clear, I am convinced that AI's breathtaking and rapidly expanding capabilities will transform healthcare in ways we can barely imagine today, bringing enormous benefits to patients and clinicians, and turning our healthcare system into one that, for once, functions reasonably well. By handling myriad administrative chores, allowing patients to accomplish many healthcare tasks independently, and permitting clinicians to be more capable versions of their professional selves, AI is poised to make our system better, safer, more convenient, and less expensive. But I am equally convinced that, particularly for patients with acute and complex chronic conditions, there will always be a need for a human guide. Someone with not only deep medical knowledge and refined clinical judgment, but also the emotional intelligence to recognize and address their unspoken fears, the leadership skills to orchestrate their care across diverse teams, the patience and wisdom to navigate the inherent uncertainties of medicine and healthcare's bureaucratic cul-de-sacs, the uniquely human capacity for deep compassion that transcends both the practical and the algorithmic, and someone to be on the receiving end of a speechless patient's kisses. They will need a doctor. Thank you so much for your attention.
Bob, thank you. As always, a tour de force. The book is called A Giant Leap. There's copies outside. You will not be charged for them. They will go fast, I expect, so please take one on the way out. We're going to open it up for questions. We have a few minutes, and I'm maybe going to start with the first one, Bob. You talked a little bit about your biggest fear about misinformation and disinformation with AI. There's a lot of things that go into AI making decisions, the black box as you call it. How do we protect ourselves from AI creating these hallucinations or these misinformation aspects, especially as we think about the high-risk jobs that we do where literally lives are at stake?
Yeah, I mean, there's going to have to be some regulatory framework for tools that give you an answer that we decide we're going to trust the answer. So the FDA, for example, framework for an AI tool embedded in a cardiology device or a radiology device or surgical to a Da Vinci robot, which all happen. It's going to have to be tested, vetted, and proved to be trustworthy. It's a very tricky job for the FDA. They do not know how to do this because they're used to regulating and approving things that are static. And this can be better next week than it was today, or worse next week than it was today. So tricky. For decision support, I can't imagine a world where the FDA process works for 100 different decision support tools that you're using today and 1,000 that you'll use tomorrow to predict or guide you on treatments and make recommendations. So we're going to have to figure that out in ways that are going to be different than anything we have today. I think ultimately there will be some flight to quality, meaning patients may learn that the wild west of the AI tools out there on YouTube and the internet are like, this thing's crazy and not trustworthy. So maybe the tool that the University of Colorado built into my chart, I can trust that because I know that someone there has vetted it. Vetting is not only making sure it's working on day 1, but making sure it's working on day 365, which means we're going to have to build in a process to test that. We're not set up to do that. And I'm quite confident that the process is going to evolve. This is hen houses and chickens in a way. It is going to involve AI, a testing, regulating AI, looking over the shoulder of a decision support AI. Gets a little bit weird and almost House of Mirrors after a while, but that's going to have to be systems that we develop.
Terrific. Questions from the audience? Yeah, go ahead, Dr. Ernest.
Thanks, Bob, for a great talk. I agree with you. I mean, having already experienced this, AI seems inevitable, right? And it is, it already is improving our practices in certain ways. And yet there are two kind of externalities that really concern me. One is I worry that AI is creating a world that humans don't want to live in. And if you look at, I mean, anxiety is part of every technological innovation, and then it's followed by a period of equilibrium. And yet it's hard to imagine like there's no equilibrium in sight with AI. It's going to change forever, and we're going to be chasing it. So that's one. And then the second really is is just the extractive component of this. I mean, we're building data centers like we have an atmosphere that can absorb more CO2 and that we have an endless supply of water, et cetera, et cetera. So it seems like in both cases, we're ignoring some realities that are going to come to bite us. And I'm just curious your thoughts on that.
Yeah, I mean, both concerns. I guess, but I can't prove that the extractive thing will get better over time and that there is extractive parts of the current economy as humans do a whole bunch of tasks that we're not sort of weighing apples and apples. But it's a concern. I mean, my biggest concern overall, Mark, is in a rational society, we would be having thoughtful adult conversations about all these things. Like if it's going to deliver a world that we don't want to live in because nobody has a job, or there are trillionaires and there are companies that, there's a lot of talk in Silicon Valley of the first company that's worth, a multi-billion dollars and has no employees. That's probably going to happen at some point. Like the big company in the Bay Area just laid off half of its workforce because it says we don't need it. So is that a world that we want to have? The answer is the capitalist system will drive us to that. If we don't want that, there's got to be a framework where we're thinking about how do we regulate that? How do we make sure it all works for people? My biggest worry is we're not having those conversations. That takes a level of political maturity that we don't seem to have in this country, and it's all systems go because we're competing against China. So I worry about it the way you do, and as I said, overall, I'm talking about healthcare, where you might say same issues, but I think in healthcare you have a field where there's real harm being done because of the cost of healthcare. There's real harm being done because of the lack of access to a good clinician that I think can be made better with these tools that would compensate, and I think compensate in a positive direction for those negative externalities. But that's my biggest worry, is these are the kinds of things we've got to talk through and think about politically, and we're just not doing it.
So Bob, thank you very much for this talk and writing the book.
Thank you.
That's wonderful. I was thinking about your discussions of AI in medical education, and then this concept of the doctor in the loop. And what are your general thoughts about, as AI is changing, how do we use medical education to train the doctor in the loop? You know, kind of iteratively, because AI is going to be changing.
Yeah.
You know, what are your general thoughts about that?
The answer is mostly I don't know. I think this is going to be something we've got to be working on in great places like this with smart people to think about, let's test doing it this way, and you know, but with a full understanding that if we let the AI take over tasks that they really need to learn, they will not learn them. And then you're into this death spiral where the AI is better than them, partly because you're no longer very good at it. I think just being thoughtful about that as people sit down and write curriculum and use these tools. I think other questions come up, and we're talking about it today. You know, should the trainees have access, for example, to an AI scribe? Or is that a foundational skill they need to have? And when I'm sure that they can do a good H&P and write it down, now I turn it on. I think that's probably smart. But I can tell you at our place, one of the things, the epiphanies we had recently, is that people making decisions about do we implement scribes didn't have an education-focused person on that committee. We need to make sure in our governance we have education as part of our decision-making, because otherwise it'll get forgotten.
Yeah. Thank you very much for your talk. It made me a little more optimistic.
Oh, good. Okay.
I have a question about this issue of hallucinations with respect to searching the literature and looking for references. I like to conduct my own searches. I'm a toxicologist on certain issues. It's not clinical decision making, it's just looking for scientific information. And I will often at the end, when I'm done with my search, query AI for a search. And it comes up with references, and it's not infrequent. I would say half the time.
Really?
Yeah, that there's a reference in there that when you,
Does not
maybe
exist.
they have five, not every reference, but
Yeah.
there's a reference in there. And when you go to that article, it doesn't contain what it said it did.
Yeah. I mean, that's a higher hallucination rate than most of the cited studies recently. What tool are you using?
Gemini.
Gemini. Yeah, and Gemini's gotten much better. Recently, they sort of leapfrog each other every few minutes. One comes out, and then OpenAI gets psychotic, and they start working on it. I'm surprised at that frequency. Basically, the frequency has gone down a lot. The companies obviously are well aware of it, that these tools have to be trustworthy. I suspect that will be a problem that 2 years from now we'll be saying, oh, they used to hallucinate. I mean, the reference problem is really kind of funny because it's such an easy problem to solve. Right. I mean, it could easily have a second AI take that reference list and query it against PubMed and say, I can't find a match here. If you can do it, why can't AI do it? So I'm actually surprised to see with that frequency. My experience has not been that high. When I'm using usually open evidence, but even Gemini or GPT, it's sort of an every now and then, and for something that's high stakes, I will double check it, but not at the level that you're seeing.
So the last time it happened, I said to it at the bottom of the query, I said, you hallucinated these references. They don't say what you said it did. And it said, thank you very much. You're right. I'm very sorry.
Yeah.
And,
it's very nice. Yeah.
And then it said, here are some verified references.
Yeah.
And it gave me some more. And then it made one of those was hallucinated.
Yeah, and you could probably say to Gemini, I only want to see references that you have verified. And I'd have to test that to see whether it will remember that. But yeah, I think this is going to be a problem that 5 years from now, they'll talk about, these tools used to hallucinate. There's no good reason that when there's a verifiable database that it should not be checking that database against its answers.
Bob, thank you. You're always a treasure trove of wisdom and optimism, so thank you very much.
Thank you.